Thank you, Professor Scambia. Thank you, Francesco, and thank you all for being here with us today. It really is a great opportunity and pleasure for me to be here and present the role of ICG for sentinel lymph node in gynecological cancers. The topic is really broad, but I will try to focus on the main aspects on the use of indocyanine green to detect the sentinel node in different gynecological tumors. So here it is. This is my outline. I will start with a background, then I will move to discuss the applications of ICG in different type of gynecological cancer. So, of course, why is the sentinel lymph node concept being so popular? It's an exciting new approach, and after decades of routine lymphadenectomy, logically refers to the natural history of cancer, while in diametrical opposition with the Halstedian concept, less is more. It's cost-effective, simplified by the use of cervical injection only for, of course, uterine cancers, and omission of isotopic tracing. ICG is basically the new standard, applicable to obese patients, and overcomes the limitation of preoperative staging like grade, depth of invasion, LVSI. Of course, the role of sentinel lymph node is to accurately identify the lymph node metastasis, which is a high prognostic factor in gynecological cancer. It confers disease upstage in the figure staging, and it tailors the adjuvant treatment. Moreover, it is important to avoid unjustified systematic lymphadenectomy with the related morbidity, intraoperative morbidity, of course, early postoperative and late postoperative morbidity. Here is a graphic picture of what are the lymphadenectomy-related complications, both during the surgery and after the surgery, in the first postoperative period and in the longer postoperative period. Moving to endometrial cancer, I want to give you a chronologic scale of the applications of sentinel lymph node in endometrial cancer, starting with the demonstration of the feasibility back in 2001. The accuracy was then proved, and we are at the time of Memorial Sloan Kettering publications demonstrating that sentinel is actually a great representative of the lymph node status of the patients. The oncological safety is been now demonstrated, even though there is not have been a formal randomized controlled trial so far. It is now broadly used the sentinel lymph node instead of full lymphadenectomy, and now we have it in the of course in international guidelines. Regarding focusing on the tracer and the site of injection, of course, it is now demonstrated that indocyanine green is superior to other tracers in order to detect the sentinel lymph node. In particular, I want to show you here the result of a randomized phase 3 multicenter non-inferiority trial, the FILM trial, which was published in 2018, and I want to acknowledge Michael Frumowitz, unfortunately not with us anymore, for being the PI of the study. This trial demonstrated that in ICG with near-infrared fluorescence identified more sentinel lymph nodes than isosulfan blue dye. And actually these trials, which randomized patients to receive either first injection of ICG and then blue or vice versa, it was the trial that makes us using the ICG today in our clinical practice. It's not the only randomized trial on the topic. I want to highlight this second randomized trial. Actually, there was a randomization per site of patients, and sites actually were randomized to receive either blue or ICG. And actually, it was demonstrated that ICG instead of blue dyes resulted in 26% increase of sentinel lymph node detection per hemipelvis in endometrial cancer, and this is a great result. Of course, there are systematic reviews and meta-analysis that are also showing the same concept. ICG is superior to the other tracer in detection of sentinel node. There has been a recent consensus statement regarding the sentinel lymph node biopsy technique in endometrial cancer, and as you can see here, there was a 100% agreement in order to say that ICG is to be considered the mandatory tracer for sentinel lymph node biopsy. Moving to cervix cancer, of course, there is a bit of overlap and the topics are similar, but I want to remind you all that even a sentinel node in cervix cancer is considered accurate with a sensitivity more than 96%. It's important that we have data that it reduced the morbidity comparing to lymphadenectomy. And it's been incorporated in the guideline, of course, with the recommendation now in the last update of the guidelines to send the sentinel lymph node in cervix cancer for frozen section in order to avoid unnecessary radical hysterectomy in case of intraoperative positivity. These are the situations where it is recommended to be used in the latest update of the ESCO guidelines. Regarding the tracer, again, I want to cite the FILM trial again, because the FILM trial was including both endometrial and cervical cancer patients. And of course, we have other reports, retrospective reports reporting that ICG is conferring higher bilateral mapping rate when compared to blue and technetium. Again, we conducted a study similar to the endometrial cancer, which was an expert consensus study to define the sentinel lymph node steps for the sentinel lymph node in cervix cancer. And again, 100% of the experts that were interviewed to define the consensus agreed that ICG should be the recommended tracer. Of course, here you can see in the box the remaining recommendations concerning the injection, 3 and 9 o'clock, superficial injection. And of course, there are some tips and tricks that now I will show you briefly. We recently looked at our experience at Gemelli, Policlinico Gemelli. Actually, we wanted to do so with other Italian colleagues, and we put on a retrospective multicenter study. We collected more than 600 cases of sentinel lymph node for cervix cancer using ICG only, and actually we demonstrated that older age and larger tumor were the factors associated with bilateral detection. We also showed that there was a slight different SLN distribution in right and left hemipelvis, and this is an interesting topic that needs to be studied. The study has been submitted and is now under submission. Before moving to the other cancers, I want to share with you some technical challenges of the ICG injection. And the first is, this is a recommendation when we discuss with David Cibola, who I give credit for this. It's important to perform a very, very slow injection, because we need to give the time. Also, Francesco Fanfani every time in the operating room keeps reminding us and the young fellows, give the time to the ICG to be uptaken by the lymph channels. Also, I recommend to do to wait 10 seconds between the superficial and the deep injections. In case of cervix cancer, it's we need to also remind that sometimes, like in the left video, it is possible to grab the cervix and have an injection. Here we have a tumor only on the posterior labia, but there are larger tumor which we still operate with radical surgery, in which this is more difficult, like in the center of the screen. And in this case, the consensus recommended, and we recommend, to avoid the injection directly in the tumor. So try to find an area of mucosa free from tumor in order to make the injection in the healthy stroma and healthy mucosa. In case there is no space at all, the group of David Cibola suggests to go beyond, so to surpass the tumor with the needle and inject beyond the tumor. Be aware that the uterus has a flexion, And moreover, when we traction the cervix, the flexion is increased, and this makes things much easier to go in the pouch of Douglas and create a spillage in the pouch of Douglas. So be careful and stay superficial, because the spillage can affect your detection of sentinel node. Of course, it's important before embarking in opening the retroperitoneal space, it's important to check the retroperitoneal migration, and then you open the space. It's important to expose all the areas where SLN can be, but of course, not injure the lymphatic channels before identifying the sentinel, because it might still need time to have the flow of ICG. Now, regarding the vulvar cancer is the oldest story, 1994, the feasibility study, and then we have the accuracy in 2000, and of course, the groin study confirmed the oncological safety, now it's in the guidelines. ICG has been more recently demonstrated to be an option in vulvar cancer. I report here the study from our friends from Spain. They demonstrated actually that ICG showed comparable performance with the gold standard, which is the radioisotope tracer. This is a review of the literature that the colleagues did in their study, showing the uses of ICG in vulvar cancer. Of course, in ICG can be used in the, let's say, let me call open groin surgery, like in the video published by Michael Mueller, or by video endoscopic approach, like the one we recently published in the International Journal of Gynecological Cancer here on the right side from our institution. Just a small picture of the situation. This is a report from America, and you can see here the trend on the use of sentinel node and the trend in the use of ICG. You can see that from 2015, first use of ICG in America for vulvar cancer, there has been a gradual growth in the use of ICG and a reduction in the use of course, blue alone or technetium alone. I want to finish by touching on the ovarian cancer. Ovarian cancer sentinel lymph node is, let's say, the latest of the gynecological cancers that was thought to use sentinel instead of lymphadenectomy, but this is still in early phases of the study. This is the first actual feasibility study showing promising results. And we have other reports that came out in the literature, the one again from Spanish colleagues from Valencia, the CENTOF study, demonstrating really high detection rate, 93% in the pelvic and 100% in the paraortic area. This is a review of the literature we did showing the last reports published in the last 5 years. And Nuria Agusti recently published a systematic review and a meta-analysis on this topic, on the use of sentinel lymph node in early stage ovarian cancer. Of course, what came out from this study is that ICG is a promising tool, but at the moment it cannot be used alone, probably because the detection rate in the use of ICG combined with technetium are higher than the ones published with ICG alone, like our study, the CELI study, which was recently published in the European Journal of Cancer, and we showed that the detection rate was actually 59% overall, but 69% in patients undergoing full study protocol. We also showed, and this is important, that ICG, of course, gave us the opportunity to identify the sentinel lymph nodes, and actually the sentinel lymph nodes underwent ultra staging, and we found many low volume metastases that could have been otherwise overlooked with systematic lymphadenectomy. In general, this is in my opinion, the take-home message regarding sentinel lymph node tracer for early stage ovarian cancer. At the moment, the combination of ICG and technetium looks to be the option in order to have a higher detection rate. Sorry, maybe I took a few minutes longer than expected, but I thank you for attending this webinar. and I take the opportunity to invite you all to the next ESGO Congress, which will be held in Rome in February 20th to 23rd. We look forward to seeing you there and to enjoy the Congress. Thank you.
Thank you, Nicola. Since we have 3 questions from the audience about your topic, I think is the best way to do quickly the answer. The first one is, what is the rationale for both superficial and deep ICG injection? And if we can skip the deep in cervical and or in endometrium.
Thank you, Francesco, for asking this question. Actually, I can see it comes
from the audience, not from my side. So
no, it's from Deepali, and I take the opportunity to say hi to Deepali. Great to hear back from you again. I think that now the literature, more than the literature, the clinical practice is moving a little bit toward the superficial only injection. Superficial only injection gives you the opportunity to have a lower dose, less risk of spillage, let's say in the pouch of Zagras, for example, with still optimal detection rate. We have to remember that in case of not detection at the first attempt, there is always in the back opportunity of the reinjection of ICG in the cervix. And this is an option that we need to take also always in consideration. So in general, at the moment, let's say the guidelines still recommend superficial and deep injection, with the superficial being the most important.
Okay, so since we have a lot of questions, I need to select only one questions to be on time. I think one of the best questions is, what is the location to inject ICG in ovarian cancer? And please answer this question, Nico, and then we move to the next speaker.
Sure. In our protocol, the CELLI trial, we designed the protocol injecting both in the infundibulopelvic ligament and the uterovarian ligament. Of course, in the infundibulopelvic ligament, it's important to stay in the subperitoneal layer, not in order not to injury the vein and the artery, of course, ovarian vein and artery, and also be careful about spillage of ICG in that.
Okay, sorry again for the unmet questions, and we have to move to the next speaker. For me, it's a pleasure to introduce Oliver Zivanovic, now in Germany, coming from the house of Sentinel Node, I mean the Sloan Kettering Cancer Center in New York. Thank you for being with us, Oliver, and please start your lecture.
Thank you so much. Can you see my screen?
Yes. Can you put in the presentation? Oh,
yes.
Thank you.
Thank you, Francesco, and thank you. Thank you, Professor Scambia, for inviting me, and thank you, Karl Storz company. I think it's a very good topic. I think fluorescence-guided surgery in gynecologic oncology is going to improve our surgeries over the next years. It already has done, as was shown by Nicolo with the sentinel lymph node mapping. I'm excited to see sentinel lymph node mapping also progressing through ovarian cancer staging. So let me just briefly say that since we have the cameras and the light source, we can target a lot of things in the body of our patients. And I think the use of fluorescence-guided surgery is not only ICG-guided, there's other fluorescent agents that can be used and maybe even more specific to molecular targets and also anatomy. And I think there's so much more to come in the next years. Anyway, so we have already touched upon sentinel lymph node mapping in gynecologic cancer, such as uterine, cervical, vulvar, and now ovarian cancer, which I'm very excited about. But there's other opportunities where we can use ICG-guided or fluorescence-guided surgery, and we have other clinical applications, such as actually visualizing targets or metastases. Also evaluating anastomotic perfusion after bowel resections. Also, we can and I think we'll see some of it later, visualize certain anatomic locations that we don't want to injure during surgery, such as the ureter or the nerves. And we can use ICG also for the closure of wounds or free flaps or flaps in gynecologic oncology. So we have heard about ovarian cancer, so I'm going to skip all that. Of course, I think the question where to inject, I think, needs to be answered. Still, IP ligamentum ovarium, proprium, fallopian tube, if it's still there. These are good questions to answer, but I think the field is going to evolve in ovarian cancer. And now I'm going to move to the use of fluorescence-guided surgery in bowel surgery. As we know, bowel surgery is a very, very common occurrence in gynecologic oncology, especially ovarian cancer. Patients in the advanced stages will require some sort of bowel resection and bowel reconstruction. And we have looked at this with Lea Mokarzel in 2021, published 410 patients in a retrospective analysis. And we have started using ICG after the anastomosis of the rectum was performed routinely after 2013. And we have collected patients and published the retrospective analysis. And we could see that ICG can help us detect areas of underperfusion in the anastomotic side. And this is, for example, a short video of a patient after an LAR, and we can see the anastomosis in a typical position, about 10-12 centimeters from the anal verge. And you can do a transanal fluoroscopy and see that there is good perfusion of the proximal anastomosis as well as the distal anastomosis. And here's an example of another patient who had a rectal resection, and you can see that even after longer time of perfusion, there is a edge of the anastomosis in the proximal area on the right side that is underperfused. And you may or may not change your algorithm, then either repeat the anastomosis or do an ileostomy or do nothing. But you can see that ICG can help us guide the surgery. And we could, in this retrospective study, certainly see that patients who were evaluated with ICG had a lower rate of complications and readmissions. And most importantly, also a low rate of ileostomies, because the surgeons felt more comfortable with not diverting the patient after seeing good perfusion. So this will lead to a prospective protocol, and has already led to a prospective protocol that is currently being performed at MSKCC with Mario Letteo being the PI. Again, the hypothesis is that the use of near-infrared technology will improve and reduce the risk of post-operative complications, also ileostomies. We have a prospective protocol which is randomized. Patients will be randomized after colorectal resection to standard of care assessment of the anastomosis or the use of near-infrared angiography. And we're enrolling a total of 500 patients, 250 in each arm. At this time, MSK is a single center, but we're trying, or Mario is trying to open it in other high-volume centers. So I think this is a nice prospective trial evaluating the use of ICG in the setting of advanced ovarian cancer surgery and bowel resection. There's other applications, such as trying to find small volume disease in the setting of advanced stage cancer. And we all know that there are some targets that can be used, folate receptor alpha, EpCAM, and so forth. And Leslie Randall has actually published pilot studies with the folate receptor assigning green-like conjugate and used preoperatively to detect peritoneal lesions. And in this pilot study, 44 patients were evaluated And in over 50% of patients, the use of near-infrared imaging was able to detect additional implants that were not seen with the naked eye. Of course, no survival outcomes or oncologic outcomes were evaluated. Nevertheless, this was FDA approved. And the problem here, in my opinion, is really, do we really, in the setting of advanced cancer such as this, where we're trying to operate on advanced disease and spend multiple hours, do we really want to see microscopic lesions, especially knowing that microscopic lymph node metastases played no role in the Lions trial. So the oncologic rationale for using ICG to detect microscopic peritoneal implants in the setting of ovarian cancer, at least for now, is not yet established. So in conclusion, I think image-guided surgery is evolving and will play an important role for our patients, not only with ovarian cancer, but with all gynecologic cancers. I think it's going to be a very important part of de-escalating surgical radicality in the future. Certainly, for me, interesting is SNL for early-stage ovarian cancer, and the use of near-infrared imaging for rectal or bowel surgery, which may have the potential to reduce radicality, maybe reduce unnecessary ileostomies and complications. The use of ICG for detection of microscopic peritoneal disease in the setting of ovarian cancer, at least for me at this point, the oncologic benefit is unclear. I think this is a theme that we have to follow in the future, maybe after neoadjuvant chemotherapy in small volume disease settings. So things are very interesting in the field of image-guided surgery, and I'm very happy to be part of this. And I think that the next years are going to be interesting, and I think we all should try to be on the side of innovation and trying to de-escalate surgical radicality by using intelligent image-guided surgery. Thank you so much.
Thank you, Oliver, for your very interesting presentation that underline how this technology can help us not only for sentinel node mapping, but for most of gynecological oncological surgery. And for this reason, it's very interesting to introduce the next speaker. Today we have no questions, so we move to the other speaker, and let's wait from the audience for a specific question. And it's a pleasure to introduce Angela Collarino from the Nuclear Medicine Department of Gemelli Hospital in Rome. She will speak about new tracers and hybrid tracers for indocyanine green and what else in gynecological cancer. Thank you, Angela.
Yeah. Thank you very much for your introduction, and I'm glad to speak with all of you about this interesting topic. Just a little bit introduction about myself. I'm Angela Collarino. I'm a nuclear medicine physician working at Gemelli Hospital in Rome, Italy. And my research pipeline is on molecular imaging guided surgery using PET and SPECT tracers. So this is just an overview of my presentation. I will speak about hybrid tracer, receptor targeted tracers, and innovative PET tracers. So the hybrid tracer is a lymphatic drainage tracers that combines in one injection radioactive components and fluorescence components. So this tracer allows to obtain preparatory imaging thanks to the radioactive, but also we have intraoperative, real-time intraoperative visualization thanks to fluorescence components. This tracer results in a high bilateral detection rate of sentinel lymph nodes, and hybrid tracer has been tested in vulvar cancer, cervical cancer, and endometrial cancer. In this pilot study using hybrid tracer in 16 patients with the early stage cervical cancer, the author found a bilateral detection rate in all patients with a higher detection rate of sentinel lymph nodes than like blue dyes. So this is just an overview about advantages and disadvantages of radio tracer, of fluorescence tracer and hybrid tracer. So radio tracer such as technetium nanocolloid, as we said, allows to obtain preparative mapping, but comes with exposition to ionizing radiations. ICG is easy to use, but has a limited depth of penetration. So the hybrid tracer combines the advantages of the two. So now we describe another topic that is receptor targeted tracer. Specifically recognize cell membrane biomarkers overexpressed in tumor cells or in the stroma. One example is a folate tracer. Folate tracer binds to folate receptor alpha, and this tracer has been tested in gynecological cancer, especially in ovarian cancer and endometrial cancer, mainly with fluorescent components. But we have also radioactive components, so we can have SPECT images. And there was also a hybrid version, so a tracer then combine radioactive and fluorescent, but the last one was tested only in mice studies, so we don't know in the clinic. Then we move to the innovative PET tracers, so to image tumor immunity, stress response, metabolism, and tumor microenvironments. One is related to tumor microenvironments and is FAPI. FAPI is a FAP, so fibroblast activation proto-inhibitors, and is a very new PET tracer with promising results. FAPI selectively binds to FAP, and as we know, FAP is overexpressed by CAFs that there are part of tumor microenvironment and there are associated with poor survival. So this is an overview about advantages and disadvantages of FAPI compared to FDG. FDG is the common PET tracer. Well, the main advantage of FAPI is the high tumor to background uptake, especially in ovarian cancer, to detect peritoneal metastasis. There are also some studies in cervical cancer and very limited literature in ovarian cancer. But of course, it's necessary to have trial studies in order to confirm eventually the potential of this new radio tracer. So then we have another innovative PET tracer, that is a folate PET tracer. So folate binds to folate receptor alpha. And currently one clinical study using folate PET tracer showed the high selectivity for folate receptor alpha, but also for folate receptor beta. So this means that we have high false positive finding, so it's not really good. But there is a new PET tracer, then you can see in the figures underlined in yellow. And this tracer has been tested in mice study showing high selectivity mainly for folate receptor alpha. So in that case, we think that we will have less false positive results. Then we speak about immuno-PET tracers. So immuno-PET is a molecular imaging modality using antibody as radio tracers. In the table, I summarize some radio tracers that could be relevant for us. Most of them are used in the clinic, but in gynecological cancer, especially in ovarian cancer, I found two interesting radio tracers. One is for folate receptor alpha and the other one is for MUC16. Both tracers has been tested in preclinical phase. A little bit more detail. The one is for folate receptor alpha and is an ADC. So we can use this antibody for treatment, but we can use also the same antibody for imaging. So when we can attach this antibody to zirconium. The other tracer is for MUC16, and with this tracer, so we have antibody, then are linked to zirconium. So we have immuno-PET imaging, and with the same antibody, we change. So the radionuclide, we can use lutetium. In that case, we can do also therapy, then it's called radioligand therapy. Of course, both of these last study are in preclinical field, so it's necessary to test if they are also, if we have also interesting results in the clinical studies. So, and thank you for your attention.
Thank you, Angela. We have a question from the audience. I believe that this question can be done for you and also for Oliver about the use of these new tracers in the era of mirvetuximab for platinum-resistant high-grade serous ovarian cancer. I think that to be honest, the meaning of the question is that if we can use the tracer for identify the malignancy, the disease inside the pelvis, inside the abdomen. This is the question, not only for do sentinel node, not only for do bowel resection in safe, but also for identify the malignancies and the disease in the abdomen, in the peritoneum. What's your feeling about this?
Yes, yes, it's correct. Our tracer, then we can use it to identify tumors. So like metastasis, for example, so our specific tracers. So we can be more specific in identification of the tumor. And the most important thing that we can have also possibility to obtain so like preparative imaging with PET, for example, but we can in the future also to use these tracer also during the surgery. This can be a next step and in the future, I think.
Okay. Okay, thank you. Oliver is writing the answer. I don't know if Oliver, do you want to say something about this?
The platinum resistant answer?
Yes.
Yeah, I think as Angela just said, I think we now have the tools to maybe see microscopic or small volume disease, which is great. But we need to know if by removing this disease surgically, we're having a significant impact on oncologic outcomes. I think that for a small early stage disease, I think it's great to have this tool. Maybe we can upstage patients, from stage 1 to stage 2 or 3, and this will have therapeutic implications. In the setting of already advanced peritoneal disease, I'm not so sure if seeing additional microscopic disease is very, very helpful. That was the only comment, and I don't think we have the data yet to support its use in the advanced cancer setting, because we don't know if we're really improving outcome survival by seeing and resecting microscopic disease.
Thank you, Oliver.
So it's now my pleasure to introduce the fourth speaker, Ignacio Zepardiel from Madrid, a very well-known gynecologic oncologist in Europe. And the topic is very interesting because we will discuss the other application of ICG in gynecologic oncology. That means guided resections, ureters visualization, and nerve visualization. And we know that the alternative applications of ICG in gynecologic oncology are increasing during the last years. So it will be a pleasure to hear how ICG can modify and can be introduced more and more into gynecologic oncology surgery. Ignacio.
Thank you. Thank you very much, Professor Scambia, Professor Fanfani. Can you hear me? Can you see the screen and everything?
Yes, yes, yes.
Perfect. Thank you very much. Thank you for the kind invitation. And we'll talk during the next 12 minutes about these further applications of ICG in GYN oncology. And I have no conflict of interest for this lecture. We will see the ureter visualization, the bowel vascularization, lymphography, and nerve visualization. That is something a little bit, I would say that probably it's under investigation. So for the ureter, the clinical utility in our patients are mainly for the obese patients, patients with adhesions, or those who are combined somehow with endometriosis. It's interesting also for bulky tumors in the pelvis, because sometimes the ureter is attached to the mass, and you don't know exactly what is the pathway of it, and it's nice to see what it is, because you can use it, remember, by laparoscopy or by open approach. And of course, sometimes for the radical hysterectomy, or even more interesting for the parametrectomy, that the pelvis is a little bit distorted, and maybe you cannot identify perfectly whether it's the ureter. It's easy to perform, so it takes like 50 minutes before the surgery to do it. It remains the color during the all surgical procedure. There is no need to maintain the catheters with the ones that we use to inject the tracer, and then it could decrease the complication rates. But actually, you need really to have complex surgeries to find it really, really useful. You see in the video, how can you see it? I think this one was with just the injection of the tracer, and you see that without any guide in the ureter, and you see that it's easily you can recognize perfectly what is running, so you can avoid any injury. We will see it in 1 minute. So for the bowel, because I will put one video of both, for the bowel, we use, instead of doing through the bladder, we do is intravenous infusion of the ICG diluted. I will tell you the dilution in 1 minute. Then we can do the intra-abdominal assessment of the blood supply. And then what we do in endometriosis is to, once we have finished the surgery with the anastomosis done, we put the umbilical trocar in the rectum, we put the camera, and then we check intrarectally the anastomosis vascularization. And if you have any doubt about the vascularization of the anastomosis, then you can cut and redo it again, just to avoid any problem with that. So this is an example of, I think this video is like 7 minutes, so it's enough. So first we will go through the ureteral assessment. What we do is a cystoscopy. We don't need the urology for this, because it's something really quick, and you just put 10 centimeters of the catheter inside the ureters, so there is no risk of damage. This is the material we need. That is the endoscope, cystoscope, the liquids, and then 6 French ureteral catheter. And sometimes we use a guide. This is the guide that you are seeing now, this wire that we put in the ureter, as you can see here, with a 6 French ureteral catheter. Once we put the guide, then we put the catheter. You see the marks. When we see 2 black lines, it means 10 centimeters. So we put the 10 centimeters and we inject the tracer. How did we prepare the tracer? We make a dilution of the ICG in 20 milliliters of distilled water. So we use 7 for one ureter, 7 for the other ureter, and then the rest for intravenously for the bowel assessment. So you can see how is the ureter seen, that it's something really easy. You can see perfectly the visualization of the ureters. Now let me check what happened here. It stopped somehow. Okay, let me see if it's running. So with the fluorescence, you can see perfectly how it's running. Okay, this is more applications. You can see it now in other kind of pelvis with a different system. This is for endometriosis in this case, but it's the same if you have a mass in the pelvis, or you can dissect under vision of the ureter, as we have seen before, and we are going to see now. The interesting thing is that since the ureter, the fluorescence, just one little trick, since the fluorescence is inside the ureter, we need to do the dissection close to the blue line, sorry, the green line, but not very close, because remember that the ureter, what is writing, is not the wall, it's inside the wall. So if you go very close, maybe you have the risk of the vascularization of the ureter. So just needs to be taken into account to be sure that you are not damaging the ureter wall, because normally the fluorescence goes a little bit out, and then you can mistake the plane. You see here how is it, and then you put the fluorescence, and it's really, I mean, this is very logical. It's very useful for some cases when you are dissecting. Sometimes you don't see what is the ureter. You put the green line, and then you see that you very easily identify what it is, so you can dissect safely without problem for damaging the ureters. You can see it here. And it's the same in other. Let's go for the. Let me move a little bit the video so we can go to the bowel. Okay. Yeah, here is it. Bowel assessment. So for the bowel, what we do is we check before the resection that the ureters are closed, but we can avoid any damage on them. So we check the integrity of the ureters before the resection. Again, let me tell you that you can apply this for cancer or for endometriosis again. This case was endometriosis. You make the resection in a normal fashion. Here you can see the ureters, both sides, the bladder up there. So you can check that everything it's out when you put the endogia. Then you make the anastomosis. And once you have done the anastomosis, you fire. Then you can check if it turns green. Normally, we to check how much green it is, we use as 100% the liver. because the closer you go to the bowel, more bright it is, so it can confuse it a bit. This is the main. You see how is the liver. The main problem with this technique is that you cannot measure exactly how green is enough. This is the main problem. And then we put the trocar in the anus once we have finished, because we cannot reuse it, of course. And we put 10 millimeters of or 8 to avoid any rupture of the anastomosis. You can see it inside, and then you put the green, and you see that the green is arriving up to the level of the anastomosis. So it's a good way to see intrarectally that the anastomosis it's good. So we put another 2 just to refresh and to be sure that it arrives. So you can see it very well. It's very easy, actually. This is something. So this is a couple of examples of what we can do with the ureters. One more thing is the lymphography. That means that sometimes you can do to see the real-time assessment of the lymphatic drainage. So you can do an ICG-guided lymphatic dissection. In some cases, could be useful. Of course, you can evaluate the lymphedema after surgery. Sometimes the lymphorea, you can check it. For example, we use the ICG in vulvar cancer. When we have lymphorea or we have a lymphocyst, we inject in the toe, and then we see the channels in the inguinal area where they flow, and then we suture them to try to solve the lymphorea of the pelvis. And sometimes you can identify the drainage for anastomosis. This is an example of how can you do a lymphadenectomy, and also in the paraortic region with the ureter. This is a transperitoneal paraortic dissection with the grasper. We are taking the IMA, and you dissect, so you can go under direct view the dissection of the nodes. Sometimes you are not sure if there are nodes, it's just fatty tissue. Let me go further just to see. You see, you can dissect, taking 100% sure that you are taking all the nodes with the channels and there is no. This is one more thing, because sometimes maybe you can have doubts, or maybe you arrive at a risky area, so you can use it just as to help, let me say. And this is the one example. This is another example where you can see how it's writing, and you can take the notes and then you can dissect. Okay. Finally, just to finish, let me show you one more thing. That is the nerve visualization. Actually, I have no experience on this, but I have seen this in literature, where they make an intravenous injection of ICG for nerve identification with the obturator nerve, genitofemoral nerve, and hypogastric plexus. It's true that in our surgeries, since we do sentinel node, sometimes it turns green more than what we would like, and then we cut the channels. At the end, I don't think that this is very useful, but this is, maybe we can make a little debate on this. And thank you very much. This is all I wanted to say. I'd like to acknowledge all my team at La Paz University Hospital in Madrid, and this is my email for whatever you need. So thank you very much.
Thank you, Ignacio. Only one question. If you can briefly repeat the dilution and the amount of milliliter that you suggest for ureteral and bowel check.
Yeah, the capsule of the ICG, it's 25 milligrams of ICG in powder. So we put 20 milliliters inside, so it's a dilution of 1.25. Then we put 7 or 8 per ureter, and we save the rest to put it intravenously for the bowel assessment. So we use all the 20 milliliters, but we use just one little bottle for the whole surgery.
Okay, thank you.
Because for the sentinel node, we make the dilution in 10, not in 20. This is only to have more volume for the ureters.
We do in 20, but it's the same.
20.
We use 4 milliliter, and I probably use 2 milliliter. In 10, we use 4 milliliter in 20. At the end, the amount is the same.
Everything works. Everything works.
Yeah. You are doing a study about this, no?
Yeah, but not for the dilution, because actually we know that the dilution, the two dilutions that are appropriate are in 10 and 20, and both works. So we were doing on the
study is deep and superficial.
Yeah, we were doing
only
that.
superficial.
Yeah.
Okay.
Yeah.
We are collecting data for you.
Thank you.
So I have a question for Nicolò, that is not only a question, but also the possibility for him to explain the role that the periureteral lateral tissue can have and how we can identify this with ICG. Nicolò, which could be the role? Can you explain us what we mean for peripult and the significance of this?
Thank you, Professor Scambia. Thank you. Thank you for this, because we are really studying this little area where we believe it's more and more important to assess the histology and the ultrastaging if possible. The initial idea actually came from studies made in Sweden by Jan Persson, and actually he, with the preliminary studies, realized that both in endometrial and in cervix cancer, there are in-transit cells that go from the uterine cervix or the uterine corpus to the pelvic sidewall, passing through what we call PULT, meaning parauterine lymphovascular tissue. It is the lymphovascular tissue overlaying and staying above the uterine arteries and veins. The ICG in this setting is quite important because it really highlights this tissue and gives us the opportunity to visualize intraoperatively and to remove it safely, of course, being safe from the ureter and the uterine artery that can be kept in situ while removing this tissue. We are really studying this. We are surveying this across gynecologic oncology to check whether the practice of removing it is just for few surgeons or it's a common practice. Of course, we do it in radical hysterectomies, but now we're moving more and more toward less radical hysterectomy after the shape, and this tissue, we believe, will gain more and more importance while having less radical hysterectomy on the uterus, but we want to have more tailored, let's say, surgical maneuvers to really detect in-transit cancer cells.
Okay, thank you very much. I don't know, Francesco, if we have other questions.
I saw that Ignazio is answering by himself, so by writing is okay. I want only to remember that in the next meeting that we have at the end of October in Marseille, the 33 ESGE meeting, there will be a section dedicated to ICG. This is I don't know if you can see the slides of the next Congress in Marseille. And on Wednesday, we will talk about the use of ICG, not for sentinel node, but all the issues that we hear today will be discussed at the next ESGE meeting.
Okay, so this is the opportunity to invite all of you to come to Marseille, because you will see in that Congress we will do a lot of discussions about advances in gynecological endoscopic surgery. And what will be interesting in that Congress, I see here Angela Collarino. She will be with us and to share with us the role that new tracers can have, and more important to me is also the role that nuclear medicine can have also as a therapeutic the therapeutic potential of nuclear medicine, because I am convinced that we are now at the beginning of a new era in gynecologic oncology, in which most of theranostics and the possibility to utilize nuclear medicine to perform both diagnostic and treatment of tumors will be the future. So, and I think also that in that meeting we will discuss and we will share the opinions among surgeons and biologists and diagnostic diagnostic people, because the future probably will be more and more a precision surgery based on a precision diagnostic and therapy. So thank you very much to all of you for being with us. Thank you to all the participants. Thank you again to the European Society of Gynecological Endoscopy for organizing this meeting. And last but not least, thank you to Karl Storz for supporting our initiative.
Thank you so much.
Thank you.
Bye-bye.
Thank you so much.
Bye-bye.
Thank you very much. Thank you.
Bye.